There are two main types of AI. So there's general artificial intelligence and there's narrow AI. General AI you can think of as basically teaching a computer to do everything that a human can do and perhaps some things that a human can't do, right? So super abilities. Whereas narrow AI, I think, is the type of AI that we all apply in medicine right now, which is to teach a machine to perform a very narrow task that a human can do.
When you think about where machine learning, and especially deep learning, can make the biggest impact, it's really in places where there's lots of data to look through. Deep learning is really good for tasks that you've done 10,000 times, and on the 10,001st time, you're just sick of it and you don't want to do it anymore. So this is really great for healthcare in screening applications, where you see a lot of patients that are potentially normal. So one of the screening applications that our group has worked on is with diabetic retinopathy. We call it DR because it's easier to say than diabetic retinopathy. And it's the fastest growing cause of preventable blindness. All 415 million people with diabetes are at risk and need to be screened once a year. This is done by taking a picture of the back of the eye with a special camera, as you see here. And the picture looks a little bit like that. And so what a doctor does when they get an image like this is they grade it on a scale of 1 to 5, from no disease, so healthy, to proliferative disease, which is the end stage. And when they do grading, they look for sometimes very subtle findings. Little things called microaneurysms that are outpouchings in the blood vessels of the eye, and that indicates how bad your diabetes is affecting your vision. Unfortunately, in many parts of the world, there are just not enough eye doctors to do this task. There's a shortage of 127,000 eye doctors in India, and as a result, about 45% of patients suffer some form of vision loss before the disease is detected. Now, this disease is completely preventable, so again, this is something that should not be happening. So what we decided to do was we partnered with a couple of hospitals in India, as well as a screening provider in the US, and we got about 130,000 images for this first go-around. We hired 54 ophthalmologists and built a labeling tool, and then the 54 ophthalmologists actually graded these images on the scale from no DR to proliferative. The interesting thing was that there was actually a little bit of variability in how doctors call the images, and so we actually got about 880,000 diagnoses in all. And with this labeled data set, we put it through a fairly well-known convolutional neural net. This is called Inception, and it's generally used to classify cats and dogs for our photo, and we just repurposed it to do fundus images. So how well does it do? So this is the first version of our model, and right here on the left is a chart of performance of the model in aggregate over about 10,000 images. We get pretty close to the doctor. These are ophthalmologists, general ophthalmologists by training. So since then, we've improved the model. So last year, about December 2016, we were sort of on par with generalists. And then this year, this is a new paper that we published, we actually used retina specialists to grade the images, so they're specialists. We also had them argue when they disagreed about what the diagnosis was. And you can see when we trained the model using that as the ground truth, the model predicted that quite well as well. So this year, we're sort of on par with the retina specialists. And this weighted kappa thing is just agreement on the 5-class level, and you can see that essentially we're sort of in between the ophthalmologists and the retina specialists. In fact, kind of in between the retina specialists. Another thing that we've been working on since beyond improving the models is actually trying to have the networks explain how it's making a prediction. So again, taking a playbook, or play out of the playbook from the consumer world, we started using this technique called show me where. And this is where, using an image, we actually generate a heat map of where the relevant pixels are for this particular prediction. So here you can see a picture of a Pomeranian, and the heat map shows you that there's something in the face of the Pomeranian that makes it look Pomeranian-y, and on the left, right here, you kind of have an Afghan hound and the networks highlighting the Afghan hound. So using this very similar technique, we applied it to the fundus images and we said, show me where. So this is a case of mild disease, and I can tell it's mild disease because, well, it looks completely normal to me. I can't tell that there's any disease there, but a highly trained doctor would be able to pick out little things called microaneurysms where the green spots are. Here's a picture of moderate disease, and this is a little worse because you can see some bleeding at the ends here. And the heat map, you can see that it picks up the bleeding, but there's two artifacts in this image. So there is a dust spot on just like a little dark spot, and then there is this little reflection in the middle of the image, and you can tell that the model just ignores it essentially. Okay, so I've given a screening application, and here's an application in diagnosis that we're working on. So in this particular example, we're talking about a disease, we're talking about breast cancer, but we're talking about metastases of breast cancer into nearby lymph nodes. So when a patient is diagnosed with breast cancer and the primary breast cancer is removed, the surgeon spends some time taking out what we call lymph nodes so that we can examine to see whether or not the breast cancer has metastasized in those nodes, and that it has an impact on how you treat the patient. So, reading these lymph nodes is actually not an easy task. And in fact, about 24% of biopsies, when they went back to look at them, these 20% had a change in nodal status, which means that if it was positive, it was red negative, and it was negative, red positive. So that's a really big deal. It's 1 in 4. The interesting thing is that there was another study published that showed that a pathologist with unlimited time, not overwhelmed with data, actually is quite sensitive. So 94% sensitivity in finding the tumors. When you put time constraint on the pathologist, the sensitivity drops, and people start overlooking where little metastases may be. So in this picture, there's a tiny metastases right there, and that's usually small things like this that are mixed. And this is not surprising, given that so much information is in each slide. The interesting thing is that pathologists can actually find 73% of the cancers if they spend all their time looking through it with 0 false positives per slide. So we trained a model that can help with this task. It actually finds about 95% of the cancer lesions, and it has 8 false positives per slide. So clearly an ideal system is one that is very sensitive, using the model, but also quite specific, that relies on the pathologist to actually look over the false positives and calling them false positives. So this is very promising, and we're working on validation in a clinic right now in terms of reader studies. How does it actually interacts with a doctor is really quite important. And clearly there are applications to other tissues. I talked about lymph nodes, but we have some early studies that actually show that this works for prostate cancer as well, for Gleason grading. So in the previous examples, we talked about how deep learning can produce algorithms that are very accurate, and they tend to make calls that a doctor might already make. But what about predicting things that doctors don't currently do from imaging? One of the great things about deep learning is that you can train very accurate algorithms without explicitly writing rules. So this allows us to make completely new discoveries. So the picture on the left is from a paper that we published recently, where we trained deep learning models to predict a variety of cardiovascular risk factors. That includes age, self-reported sex, smoking status, blood pressure, things that doctors generally consider right now to assess a patient's cardiovascular risk and make proper treatment recommendations. So it turns out that we can not only predict many of these factors, and quite accurately, but we can actually directly predict your 5-year risk of a cardiac event. So this work is quite early, really preliminary, and the AUC for this prediction is 0.7. And what that number means is that if given 2 pictures, one picture of a patient that did not have a cardiovascular event, and one picture of a patient who did, it is right about 70% of the time. Most doctors and is around 50% of the time, because it's kind of a random, like it's hard to do based on the retinal image alone. So why is this exciting? Well, normally when a doctor tries to assess your risk for cardiovascular disease, there are needles involved. Take some blood samples, and then we assess your risk. These results support the idea that we may be able to use something like an image to make new predictions that we couldn't make before, and this might be able to be done in sort of a non-invasive manner.
The reason we're focusing initially some of our efforts on diabetes is this is an urgent health issue. About 1 in 10 people has diabetes. And when you have diabetes, it affects how you handle sugar or glucose in the body. And if you think about pre-diabetes, the condition before someone has diabetes, that's 1 in 3 people. Now, what happens when your body handles glucose in a different way? You can have downstream effects. You heard Lily talk about diabetic retinopathy. People can have problems with their heart, kidneys, and peripheral neuropathy. So this is the type of disease that we need to get ahead of. But we have 2 main issues that we're trying to address. The first one is an information gap. So even the most adherent patient with diabetes would check his blood sugar 4 times a day. And I don't know if anyone today has been able to have any of the snacks. I actually had some of the caramel popcorn. Great, right? Except probably our biology and our glucose is going up and down. So if I didn't check my glucose in that moment, we wouldn't have captured that data. So we know biology is happening all of the time. When I see patients in the hospital as a cardiologist, I can see someone's heart rate, their blood pressure, all of these vital signs in real time. And then people go home, but biology is still happening. So there's an information gap, especially with diabetes. The second issue is a decision gap. You may see a care provider once a year, twice a year, but health decisions are happening every single day. They're happening weekly, daily, hourly. And how do we decide to close this gap? The first thing to think about is the collection of data. And one thing that has been absolutely revolutionary is thinking about extremely small biocompatible electronics. So we are working on next generation sensing. What this will lead to, for example, with extremely small continuous glucose monitors where we're partnering to create some of these tools, this will lead to more seamless integration. So again, you don't just have a few glucose values, but we understand how your body is handling sugar or someone with type 2 diabetes in a more continuous fashion. It also helps us understand not only what happens at a population level, but what might happen on an individual level when you are ingesting certain foods. So here there's an app that prompts for the photo of the food, and then using image recognition and using Google TensorFlow, we can identify the food. And this is where the true personal insights start to become real. Because if you eat a certain meal, it's helpful to understand how your body ends up relating to it. And there's some really interesting preliminary data suggesting that the microbiome may change the way I respond to a banana, for example, or you might respond. And that's important to know because all of a sudden, those general recommendations that we make as a doc, so if someone comes to see me in clinic and they have type 2 diabetes, I might say, okay, here are the things you need to do. You need to watch your diet, exercise, take your oral medications. I need you to also take insulin, exercise. You got to see your foot doctor, your eye doctor, your primary care doctor, and the endocrinologist. And that's a lot to integrate. And so what we try to do is also pair all of this information in a simple way with a care lead. This is a person that helps someone on their journey as this information is surfaced. This is showing you the difference between the data you might see in an episodic glucose example or what you're seeing with the continuous glucose monitor enabled by this new sensing. And so let's say we drill down into this continuous glucose monitor and we look at a cluster of days. This is an example. We might start to see patterns. This is not the type of thing that an individual patient, care lead, or physician would end up digging through, but this is where you start to unlock the power of learning models. Instead of giving general care, we can start to target care in the most comprehensive and actionable example. So again, thinking about what we're talking about, collecting data, organizing it, and then activating it and making it extremely relevant. So that is the way we're thinking about diabetes care, and that is the way AI is going to work. And the thing that's important, there's going to be room for healthcare providers. What these tools are doing is merely helping us do our job. So sometimes people ask me, is technology and AI going to replace physicians or replace the healthcare system? And the way I think about it is it just augments the work we do. If you think about the stethoscope, so I'm a cardiologist, and the stethoscope was invented about 200 years ago. It doesn't replace the work we do, it merely augments the work we do. And I think you're going to see a similar theme as we continue to think about ways of bringing care in a more effective way to patients. There's a promising pilot that's currently ongoing both here as well as in India, and we're so encouraged to hear the early feedback. We're seeing higher accuracy with AI than with the manual grader. And then the second thing is to think about that face of patients. How do we truly democratize care? And so the other encouraging piece from the pilot was this idea that we could start to increase the base of patients treated with the algorithm. There's a huge opportunity, not only in diabetes, but really in this entire world of health information. It's interesting to think about it as a physician who spends most of my time taking care of patients in the hospital. How can we start to push more of the access to care outside of the hospital? But I know that if we do this well, and if we stay ahead of it, we can close this gap. We can figure out ways to become more preventative. We can collect the right information. We can create the infrastructure to organize it. And most importantly, we will figure out how to activate it.
The 2020 pandemic has challenged our healthcare systems in many ways and put a big strain on our frontline workers. However, it has also opened the door to a greater acceptance of robots and automation. So what will the future of robotics in healthcare look like? One can imagine a not too distant future where in an operating room, there's a robot nurse assisting a surgeon. In another operating room, a robot is performing the surgery teleoperatively. And maybe in another, a surgeon has just introduced a swarm of micro-robots into a patient to eradicate a disease. After the surgery is done, a cleaning robot enters to quickly disinfect the operating room to get it set up for the next procedure. And then down the hall, there's a post-op patient who is learning how to strap on a soft exoskeleton robot to guide their customized rehabilitation program, what they can do to the comfort of their own home. Down in the clinic, patient samples for testing exposure to potentially deadly airborne virus have been sent off to an automated processing facility, which is capable of processing thousands of tests a day. Nearby, a patient is waiting to receive a newly prescribed drug. Do they know that a drug discovery lab was able to use robotics and automation to rapidly screen millions of cells with different compounds in order to discover this new treatment?
I can see more robots being deployed to remove manual handling challenges. An obvious one is a bed, a hospital bed. There's a lot of porters that push people on trolleys, wheelchairs, or beds, or push or pull, either way. And I could see robots doing that task fairly easily and allowing humans to do work which perhaps might be deemed of high value. I could foresee robots delivering things within the hospital environment, whether it be medicines, whether that be food. And I think those are kind of not so far away from where we are now, that they're kind of more on the horizon.
When we are looking into the next 10 or 15 years, I start looking into procedures that are going to be small procedures and simple procedures that people will be able to get done through robotics. I think that we're going to see teams of robots and humans working together rather than being controlled. It's going to be some form of hybrid form of future work. I do think that we're going to see more and more autonomy in surgical robots. You know, the big companies like Surgical Intuitive, Mazor, and others are very cautious about how to go about it. So they focus mostly on teleoperation and telerobotics, where the surgeon is the person controlling what's going on. But we know from research and current experiments and prototypes that robots working, for example, using autonomy and artificial intelligence are quite successful in several tasks like incisions, closure, knot tying. There is multiple procedures that are simple, that are very simple, and robots are faster than humans. So, I think that is going to happen, but in the same way that right now people may be scared to get into an airplane that is going to be fully autonomous, even that technically autonomous cars, for example, exist, and people may be willing to step into an autonomous car. When you talk about an airplane, they are concerned about that. They are really scared. So in the same way, going into a surgery when you know that the robot is fully autonomous is going to create a lot of reluctancy. And until we get to the point that people will get over those initial barriers, I think that it's going to take quite some time. And which is, again, not necessarily an issue of technological developments. It's more an issue of getting used to those ideas and making sure that the people expressing these concerns are being heard.
I don't think the role of physicians is going to go away. Medicine is inherently a human enterprise. And that empathy, that human element of caring for another person is not something that an algorithm can reproduce.
Subscribe us.